All right, hold on, let me underline the word don't, because I was gonna do just the opposite. I'm so bad at this holding things. Yeah, thanks. Tell me that doesn't look like a child who was seriously burnt. Thank you for the use of your computer. Don't drop it.
Okay. That was don't drop it.
Underline. No. No. Do this also. No. No. So good, okay. Ah. 20-year-olds fire. Oh, no. 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 Good. Time to get through that and then some. So we have some time for some muscle review, where we can see it on cadavers. The main muscle. What chapter do we have on Monday? We have like, yeah, we have 2 parts of the nervous system, right? Some big stuff. The good news about the nervous system is difficult, it really is. But the good news about the nervous system is don't feel bad if you don't understand everything, because no one does. There's just so much about the brain we don't understand. They've estimated that before, but it's going to be so long before we have the capability to actually do like a brain transplant that a UFO will probably land on the front lawn of the White House, and Elvis Presley will step out of it before we actually figure out how to do a successful brain transplant.
The guy from Grey's Anatomy would.
I'm sorry?
The guy from Grey's Anatomy will figure it out. Derek Shep.
I don't know who that is.
He's the guy from Grey's Anatomy.
Oh, okay, the guy from Grey's Anatomy, okay.
The show.
You know, before it was a show, it was a book, right? You know that? Yeah, it was very, it was a book, and it was important. Those things like that. I read that somewhere. Well, we skipped a couple of breaks, right?
Couple.
2, 4. We did not skip 4 breaks.
Feels like.
That just makes me feel bad. Why would you say that?
Because you weren't talking about getting fired or losing your job or.
That's what keeps your attention. I'm just getting fired. Nobody cares. Nobody cares I get fired.
Drop that. Yeah, you'll reap benefits.
Alright, here we go. That away. Temporalis, right? Remember when we strip down to here, we see that it attaches right to the only movable bone in the cranium? Mandible. What muscle is this right here? Sternocleidomastoid. What about this muscle right here? Trapezius. What about this muscle right here? Frontalis. Frontalis. Right here. This is the orbicularis oculi. Around the lips, orbicularis oris. Here you can see the platysma. See this very thin muscle? It's kind of see-through, in fact, right here. This is the muscle that helps to bend the chin down to the chest. It also assists in opening the jaw. Remember, the lateral pterygoid is really the muscle that opens the jaw, but this assists. We have three muscles keeping it closed. What happens if I'm lying down on my back and all my muscles are totally and completely relaxed? What's going to happen to the jaw? It's going to drop down, which is why you see dead people after a couple of days, several days, weeks, look like they're screaming, right? Their jaw's wide open. Well, this is gravity. So this is a very, very thin muscle. When we're talking to medical students, or you're watching medical students, they'll be told to be very careful cutting this area because they'll slice right through the platysma and not even see it. So you strip that away and we see this muscle right here. It's the sternocleidomastoid. Back here again is the Let's go. Sternocleidomastoid, trapezius. This right here, deltoid. This right here, pectoralis major. You can just barely see a little bit of the serrator anterior here. Remember, this is the boxer's punch, boxer's muscle. This muscle back here is the latissimus dorsi. Did I go over that one? I don't think I did. It's in the book. The latissimus dorsi, that's the big muscle in the back. This is the muscle that you use when you're pulling yourself up. You're going to pull up or pulling something down, or even pulling something towards you. Use this big latissimus dorsi muscle back here. You can see right here the external abdominal oblique muscles, and you can see the angle that they go. Here's the aponeuroses. Pectoralis minor. Oh, I don't think we talked about that one. Okay. Here is the bicep. All right. This is what? What bony process is right here?
The coracoid.
Very nice. Coracoid process. This looks like it attaches at the humerus, but does it?
No. Glenoid process.
Correct. All right. This right here.
This abdominal.
What's rectus mean?
Straight.
I think this next one shows it a little clearer. Pectoralis major, aponeuroses. Here's the inguinal canal. This right here is a spermatic cord. And that's going to contain the blood vessels going to and from the testes, the nerves, and the vas deferens coming from the testes and going into the urinary bladder.
What's it called?
The spermatic cord. Remember, this is where the testes move from the pelvic cavity down into the scrotum. Before the baby's born, as the testes are developing, they develop inside of the pelvic cavity. And about a month before birth, they move. They move down through here and into the scrotum. Now, of course, the subcutaneous layer is still in place. They move down through here and into the scrotum. And they bring with them the spermatic cord that has all the blood supply and, of course, has the vas deferens that's going to bring the sperm back in, back around to behind the urinary bladder. This is something the pediatrician will look for. Your pediatrician looks for this on all those newborn baby boys. If it has not descended when the baby is born, then they start getting worried. I think they give, what is it? The recommendation by the American Association of Pediatricians, or whatever their association is that if it is not descended, that it must be surgically descended within a year or by 12 months. but most, I think, tend to start making plans to do surgery by the 6-month mark. So they don't wait the actual whole year. And even if it does descend on its own, a month later or 2 months later, increases the risk of testicular cancer. So this is something they have to pass on to mom. All right. So here, look at the external oblique muscles. Now once we take the aponeuroses away, the internal abdominal obliques, you see the angle they're going? They're going up this way. Whereas the external went down. Internal, external. Internal, external. Internal, external. Internal again. And these, of course, are the rectus abdominis. These are the straight muscles. You can see how straight they are. And what are these muscles up here? Tasty. Delicious. Look at that. What do you think we'd call these?
Transverse.
I would call them transverse. I don't know about you, right?
Oblique.
And there are our iliopsoas.
What's the origin of iliopsoas?
Hold on, let me think. Psoas is on, I think it's on the vertebrae. The iliopsoas is on the ilium. Somehow it attaches to the vertebral column. So I'm not sure if that's the origin of the psoas or not. Maybe it's just another insertion. I don't remember. Because what's it do? It's going to pull the body. It's going to help to pull up and rotate. So it externally rotates, right? So it's going to pull up and rotate. So it's going to have to pull towards the origin.
Attached to the last thoracic vertebra.
Attached meaning origin? Yeah. Kind of makes sense. Kind of. I think. We have, okay, here, you can still see the spermatic cord coming down into the testes. Which lumbar vertebra? Third?
The last
Or last?
thoracic.
Last thoracic, not lumbar, okay.
Oh,
Last
yeah,
thoracic,
sorry.
and
My bad.
this says lumbar 1 through 5.
Okay. Sorry. Nice.
This is saying it's actually a composite muscle. So it's a combination of the psoas major and the iliacus.
Iliacus. Yeah, you can see it there.
Sorry, I didn't mean to sidetrack.
That's all right. I think we have time for sidetrack. You can see you can see how large the latissimus dorsi muscles are. Well, the lats. Yeah. Right there. Yeah. deltoid again, bicep again. Brachioradialis, so did I mention the brachioradialis before? Okay, good. This right here is the brachioradialis.
Just a small bug fixation. Is that the one there?
Brachialis assists, that's the one that assists in flexion. That's the one that has the origin in the humerus and then goes over the ulna. This one, interesting thing about the brachioradialis is it helps in flexion down here, but it also helps in supination, but it also helps in pronation. It can actually do both. It can actually assist in both, depending upon whether it's in the process of flexing or not. Yeah. It's interesting. And it's also the biggest muscle of the forearm, so it's easy to remember that way. I think that's interesting. I don't think we can. No, we don't do both. We don't get it. Okay.
So these are all in, are they true color? Or do they increase contrast between muscle fiber and tendon?
This is, I think this is pretty close to true color. I don't think they did too much with it, but it's not fixed cadaver, and that makes a difference. You know, if a cadaver is fixed in formaldehyde, everything's brown. It's just different shades of brown. It's more brown or less brown. And I think that's what you're seeing here is the fact that it's not. But I don't know what else they may have used with this to help the colorization. If you look right here, this is the palmaris longus. This is the one that you could see if you do this. Flex your wrist. Flex your wrist. Touch the tip of your pinky, the tip of your thumb. That's this one right here. Here's the brachioradialis. Notice the thenar muscles. Big group of muscles here, and then the hypothenars over here. Notice how in prosection we keep the fingertips on, because these tendons stretch all the way up to the tips of the fingers. So if you were to dissect out that completely, the tendon would just spring loose, and you'd end up with these tendons just flopping around. It would be difficult to know which one went where. So whenever they're prosected like that, you'll see they keep the fingertips on. Pretty good job. Actually, a really good job. You can't quite see, can't quite see the tuberosity there. Oh no, I don't need to see that. Oh well, you know what? Let's see a posterior wrist and hand. Because here we can see, there it is. This is the retinaculum. The retinaculum is going to help keep all these tendons in place. So they stretch all the way up. It's hard to make out some of the quadricep muscles either. You can hardly even make out the sartorius muscle. The vastus lateralis, you can see. Not the other ones. There's just so little muscle mass left in this area.
What is the vastus intermediate and the rectus femoris that are on top of each other?
Yes. Yeah. Intermedius is the one that's sort of buried a bit. Can't see it. Can't see much of anything on this one. You see how big this muscle is here. It's pretty big. I can tell which is semitendinous, which is semi-radius. But the bicep more, that's about it.
What's that in the middle there?
Oh.
Never mind.
what it was? That I just put the line down? Looks like a line going down?
Yeah, in between the muscle.
Big blood vessel?
Is that what it, yeah.
Big artery? What artery that is?
The big vessel.
That would be the femoral artery. It's the only huge artery there. Which other one would it be? Try and spot another big artery in the leg. That's as big as it's gonna get down there. Because remember, that's coming right off of a branch of the common iliac arteries. It is the common iliac artery until the common iliac artery branches off. And then what's left is the femoral artery, and that's huge. Yes. Gastrocnemius, the stomach. What? The stomach of the leg. Gastro means stomach, right? It does. So this is the gastrocnemius muscle. It's the stomach of the leg. Why do you think it got that name? It bulges out. Looks like a stomach. Think I'm making this stuff up, man? Oh, what is this right here? Here we go.
Achilles.
Achilles. Board. Okay, hold on. This is cool. Okay. Here's what's going to happen. We're going to have a signal coming down the nerve in the form of an action potential, which means positive and negative signs, just about charges coming down here. When it reaches this point, this is a calcium channel. When it reaches this point, it's going to cause that calcium channel to allow calcium to come into the end of the neuron. What that means is that these vesicles that are filled with acetylcholine can now leave. That's the signal for them to leave. So we have an electrical signal coming down here that is going to convert to a chemical signal. The chemical signal is going to cross this space. It's going to flood this space, bind to these receptors here. These are the sodium channel receptors. Sodium is going to come in, and that will depolarize the cell.
An action potential arrives at the presynaptic terminal, causing voltage-gated calcium ion channels to open, increasing the calcium ion permeability of the presynaptic terminal cell membrane. Calcium ions enter the presynaptic terminal and cause vesicles to release their neurotransmitter acetylcholine from the synaptic vesicles into the presynaptic cleft. Diffusion of acetylcholine across the synaptic cleft and binding of acetylcholine to acetylcholine receptors on the postsynaptic muscle fiber membrane causes an increase in the permeability of ligand-gated sodium ion channels. The movement of sodium ions into the muscle cell results in depolarization of the postsynaptic membrane. Once threshold has been reached, a postsynaptic action potential is generated and is propagated over the muscle cell membrane. Acetylcholine is rapidly broken down to acetic acid and choline in the synaptic cleft by the enzyme acetylcholine esterase.
That's the recycler.
The choline is reabsorbed by the presynaptic terminal and combined with acetic acid to form more acetylcholine, which enters the synaptic vesicles.
So you can imagine that if we stopped this guy from doing his job, then the acetylcholine is not going to get broken down, which means it's going to stay in this space, which means it's going to continue to activate these receptors, which means sodium is going to continue to come in, which means now the cell is going to depolarize. In other words, in those patients who have myasthenia gravis, when we give them that short-acting acetylcholine esterase inhibitor, it's going to block these from doing their job. It's going to keep that neurotransmitter in the space longer. It's an important concept because we'll see it again. You ever hear of the SSRIs?
Mm-hmm.
What does SSRI stand for? Selective serotonin. In other words, not all serotonin. Selective serotonin reuptake, meaning coming back into the presynaptic terminal, inhibitor. It's going to stop serotonin from going back in here, which means it's going to keep it in this space longer. It's an important concept.
In a relaxed muscle, actin and myosin myofilaments lie side by side, and the H zones and I band are at maximum width.
That's not the one I want yet. Okay, that's what I want. So, from the neuromuscular junction, we saw the depolarization of the muscle cell membrane. Acetylcholine caused the sodium channels to open up, sodium comes in, depolarization occurs. So now we're back to an electrical message. We went from electrical message, changed it to a chemical, now we're back into electrical. It's about a charge. We're back to charge. And that charge is going to go down this membrane. It's going to go down this area right here, which is this area here, which is referred to as a T-tubule because it's T-shaped. But it will go down here, and what will happen is it will open the doors, the floodgates, for the sarcoplasmic reticulum right here that is inside of the muscle cell. That depolarized cell membrane is going to cause the sarcoplasmic reticulum to release calcium within the cell. The calcium is going to come over here, and it's going to make available the binding sites. It's going to uncover the areas, the handholds, the grip, where you can see this big filament is going to grab onto.
An action potential introduced at the neuromuscular junction is propagated along the sarcolemma of the skeletal muscle. At the T-tubule, the action potential is propagated on the T-tubule membrane into the interior of the muscle cell near the ends of the sarcoplasmic reticulum. The depolarization of the T-tubule membrane causes nearby voltage-gated calcium ion channels on the sarcoplasmic reticulum to open, resulting in an increase in the permeability of the sarcoplasmic reticulum to calcium ions.
See what happens with
Calcium ions then diffuse from the sarcoplasmic reticulum into the sarcoplasm.
In other words,
Long filamentous tropomyosin proteins lie on two sides of the actin.
okay, shut up. In other words, we have this, inside of the cell, we have these storage compartments of calcium. That depolarization, that change in the cell charge, in the cell membrane, that is the message that came from the neuron, as it travels down next to these storage units, it's going to open the storage units. It's going to allow them to open up and calcium to come out into the interior of the cell. It's not going to leave the cell. It's going to stay inside the cell. That calcium is going to come over here, and you see the tropomyosin. It's going to take that, it's going to move it, well, it'll say
Actin myofilament, covering up the sites where myosin can bind to the actin myofilament. Globular troponin proteins are attached to the tropomyosin. When calcium ions bind to troponin, this causes troponin to change conformation and move the tropomyosin. When the tropomyosin moves, this uncovers the myosin-binding sites on the actin, allowing myosin heads to bind and form cross bridges.
So this up here is the thin filament. The place where the thick filament was going to grab on was covered up. Calcium came down and caused that to uncover. Now the thick filament can grab onto the thin filament and pull like this, and pull like this, and pull like this, and that's going to cause the thin filaments to move closer together.
The cross bridges play a role in muscle contraction.
So, notice how the thin filament is anchored right here, and then this one is anchored here and here. See the pattern right here? This is the Z line. Here's a Z line. From Z line to Z line is one sarcomere. So what's going to happen is this big, thick filament is going to pull these filaments this direction, closer to the middle. Since they are attached, they're going to end up pulling this Z line closer to the middle, this way. And then the same thing's going to happen on this side. It's going to pull these filaments toward the middle. So we're going to have the Z line to Z line is actually going to get pulled closer together. And that is the one sarcomere. Getting short.
During contraction of a muscle, calcium ions bind to troponin. This moves tropomyosin out of the way and uncovers binding sites for myosin on the actin myofilaments. ADP and phosphate are attached to the myosin head from the previous cycle of movement. The myosin heads attach to the exposed binding sites on the actin myofilaments to form cross bridges, and the phosphate is released. Energy stored in the head of the myosin myofilament is used to move the head. This causes the actin myofilament to slide past the myosin myofilament.
You see the ATP was already there in the form of ADP plus P? In other words, it was already there, it had already been used, sort of.
The ADP is released from the myosin head as it moves.
Just watch what happens.
The bond between actin and the myosin head is broken when an ATP molecule binds to the myosin head.
So to get relaxation to occur, we actually have to have ATP, we have to have that for the muscle to relax. We have to have new ATP for the muscle to relax. See that?
The ATP is broken down to ADP and phosphate, releasing energy, which is stored in the myosin head and will be used later for movement. The head of the myosin molecule returns to its upright position and is ready to bind to actin again. If calcium ions are still present, the entire sequence is repeated.
Where's that energy go that when it's, once it grabs the ATP and it drops down and it releases the phosphate right now? Yeah, there. Where's that energy go?
What do you mean, where does the energy go?
Well,
Energy
there's
is
energy
utilized
how?
in movement.
To relax back?
Yeah. So the muscle is then going to relax back. But it has to have new ATP to do that. This is now old ATP, what you see here, ADP and phosphate. So in order to relax back, you have to have new ATP. This is why when somebody dies, after a couple hours of their death, they end up with the sarcoplasmic reticulum releasing calcium within the cell. So what happens is, well, what's supposed to happen? When calcium floods the inside of the cell, it releases those binding sites. When those binding sites get released, we got ATP and inorganic phosphate there. So it's going to do what it's supposed to do. It's going to grab on and it's going to pull. Which is why you see dead people go into a stiffened rigor mortis. Because their muscles are contracting. Why won't they relax? Because there's no new ATP. Why is there no new ATP? Because they're dead. They're not making any new energy. So you see, this is now old ATP, ADP, and inorganic phosphate. It's already ready. This is like setting that mouse trap. You know, you got it ready to go. All you have to do is have something kick the switch. Well, it doesn't matter if it's a mouse, if it's a finger. The energy is already stored right there. All you have to do is hit it and it'll lock on. Well, that's what's happening here. That's already in that locked position. So as soon as calcium comes in there and moves those binding sites out of the way, it prepares it, moves the troponin out of the way, well, it's going to do the same thing. It's going to latch onto it, and it's going to pull, because that's what it does. It just isn't going to know to let go. Then why does it let go eventually? I mean, dead people aren't always like this, right? After another day or so, what's going to happen? Well, those cells, that tissue, is going to break down. It's going to die, because it's already dead. The person's dead. So the tissue's going to die. Cells are going to die, which means you're going to lose their integrity. Which means, because of things like gravity, they're going to fall apart. Does that make sense?
Is there,
I think rigor mortis is an important concept for you guys to understand. Hold on a second.
In a relaxed muscle, actin and myosin myofilaments lie side by side, and the H zones and I band are at maximum width. During contraction, the actin and myosin myofilaments interact. The actins slide toward the center of each myosin myofilament. As a result, the sarcomeres shorten. In the fully contracted muscle, the ends of the actin myofilaments overlap. The H zones disappear. and the eye band becomes very narrow.
Okay, now what you have to imagine is there's another sarcomere here, and another one 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 here. And that makes up that myofibril, that tube that is inside of the muscle fiber. And then there's a whole bunch of those tubes inside of that muscle fiber. So when this shortens, and this shortens, and this one shortens, and this one shortens, and this one shortens, that whole tube, shortens. And all of the tubes shorten. And that whole muscle cell, muscle fiber, shortens. And this is happening in that muscle fiber, as well as the muscle fiber right next to it, and the ones next to it, and they're all bundled in this package called a fascicle. So the whole fascicle is all shortening at once. And then, of course, a bunch of fascicles are all packaged together into a muscle, which is all shortening at once. So that's a lot of stuff going on just for that marker to be thrown and then caught again. Really? That's a lot of stuff that's happening just to do something as simple as catch a marker. You know, and that's happening in not just one muscle, because you can see. Oh, that was a horrible video. Okay, so if I throw it like this. Sorry. Notice how he had to change his position quite a bit. He had to change his shoulders. His eyes had to follow it up here. He had to move his arms up this way. So that's a lot of muscles happening. All those muscles are undergoing the same thing. Starting out with, maybe not thought up here, but starting out with that electrical signal going down a nerve, down to the muscle, being changed into a chemical, then changed back into an electrical current, releasing the calcium binding, moving that out of the way, myosin grabbing, acting getting pulled, sarcomere shorten, myofibril shorten, muscle fiber shorten, fascicle shorten, muscle shorten. That's a lot of stuff. Seems to care. I don't know why I do this. All right. What bone is this? Are you sure?
Pretty sure.
Not pretty sure. Are you sure?
Yes.
Why are you sure?
Because it attaches to the.
No, start out before that. I don't know, you said you were trying to book.
It doesn't matter.
Okay. It doesn't matter if that's the humorous? I disagree.
No, it doesn't matter what I said, because it's not a foot.
Because it's not a foot. That's true. I'll give you that. Okay, partial credit.
Proximal end of the ulna is bigger.
Even before that.
It's not big.
How many parts of the body do we have where we have one long bone that meets two long bones?
Two.
Arms and legs, right? So now we've narrowed it down to either this is an elbow joint, where the one meets the two, or this is a knee joint, where the one meets the two, right? That's the very first thing we did. The next thing we did was looked at this right here. This certainly hinges up and around. There's no space in between here. This hinges up and around. Which one of these joints hinges up and around? See how easy? Right? Why did you miss this? It's easy. Okay. We have interesting stuff going on, man. The neurology stuff is so incredibly complicated.